My name is Don Keys. I oversee GME. I want to welcome everybody tonight to the second session on patient safety and quality through our GME core curriculum. So tonight we have, in September, you guys had a session with Josh Clark, introductory section about patient safety and quality. Tonight's going to be delivered by Christine Gorman and Lori Wolf. Both of these presenters actually are industrial engineers. I just learned that. So, and Dr. Wolf has her PhD in human factors. So, I'm married to an engineer, so I understand engineers. So anyway, tonight's going to be very interactive. I hope you guys get a lot out of it. And a few things real quick. If you do not sign in, you are not here. Do everybody understand that? If you do not sign in, you were not here tonight. So please sign in. After these sessions, my office always gets called, oh, I was here, I just didn't sign in. Well, you know you guys are adults, so please sign in. If your colleagues come in a little bit late, nudge them. Say, go to the back and sign in. All the papers that were out here will be brought to the back, so the sign-in sheets are there. So please, please sign in. And I think that's our only announcement, and I'll turn it over.
All right, we're going to get started and try to get you out of here a little bit early today. So my name is Lori Wolf. My master's degree was from Virginia Tech in industrial engineering, but recently, about 2 years ago, I got my PhD at Loughborough University in human factors engineering. And I went overseas because they do applied research, and the human factors over there is a little bit different than we have here in the United States. So I specialized in patient falls. So that's a little bit about me. I have spent the last 10 years doing quality improvement work, and I'm also a certified Six Sigma from American Society of Quality. So I'm interested in blending quality improvement and human factors together. So today's class is going to be bringing together concepts that you've learned in previous classes. So you had a class with Josh on systems thinking, learning how to think beyond just your scope, but considering the whole process. So we're going to talk about that a little bit, bringing that in. The safety culture, what's the organization like? What's the standard way or accepted way that the people are doing the work on the floor? Each floor can be a little bit differently. Each culture is different. So how do you consider that when you are trying to evaluate what happened with an adverse event that might happen in the hospital? We had some information about human factors, and when you're actually looking at some error that happened, look beyond a human cause. So if that is one of the contributing factors as a human made a mistake, we talked about the kinds of errors and why humans make mistakes. So we want to ask why. There has to be another reason beyond just blaming the human. So go think beyond that. And then we talked about teamwork. Dr. Parker taught us a class on humans' capabilities and limitations and teamwork, and then how to look at outcomes and data and trends. So we're trying to pull all that together and talk about, we're going to have two different scenarios that we're going to talk about today and have hands-on actions. You get a chance to try some tools out according to these two scenarios we're going to talk about. So we're going to stop talking now and actually apply this with some scenarios. Before we do that, though, we are going to talk about different kinds of methods of process improvement. So have anybody heard of the Plan, Do, Study Act? Plan, Do, Check Act. You've heard of that? That's been around for a long time, and it just means scope what you want to do. If you have a problem and you want to solve it, scope it correctly, define what you want to do, spend some time solving that problem, then go out and do the intervention to fix it. Then you have to analyze and study that it worked, because sometimes you can create a problem that you didn't realize was going to happen, and so you need to readjust. And then that's what the ACT piece is. So make some adjustments until you keep going around that circle until you achieve the results you want or the outcomes. So that's one method. How about lean? Has anybody heard about lean? What do you think lean might mean? I'll give you a hint. Lean comes from the manufacturing environment. It's been in the healthcare world now for a little over 10 years. Any suggestions? Never heard of lean? What's lean mean in hamburger?
Less fat.
Less fat. Take out the waste. That's what lean, overall, if you have to summarize lean in a couple of words, it's taking out the waste. So there are wasteful things that happen in the hospitals. Do we ever wait on anything in a hospital? Does anybody ever wait? You guys get everything when you need it, always where you need it. So there's waiting for everybody. Even our machines, like MRI machines, wait for patients to get in there. So lean is a way to take the waste and the waiting out of healthcare. It's a very quick reacting method that can follow the Plan, Do, Study, Act issues, but it's usually fairly short term. Another methodology is Six Sigma. Have you heard of that? That's been around also for about 10 years, too. It takes a little longer to do a Six Sigma study. In a Six Sigma study, you go through similar processes as Plan, Do, Study, Act. So you define your problem, you measure it before you do anything because you want to get a good baseline data. You then improve, brainstorm suggestions, and you make the improvements. Then you analyze whether that improvement worked, so take some more data and make sure that it got the improvements that you thought it would. And then the final one is the sustain part, so controlling. Once you make your interventions, it's very difficult to sustain it. We have a very complex, constantly changing environment in healthcare. Even our employees constantly change over. So once you get something in place, to keep it and sustain it is a lot of work. And so that's what the Six Sigma process is, a little more detailed, takes a little longer. It's very data driven and process oriented, but it demands that you look at it, each problem from a systems perspective. And then no matter which one of these process methodologies we use, we must have project management involved with it. If it is a big project that we need to keep track of many different subgroups to get something done, a project manager will help make sure that we have milestones. What are the milestones that need to be met and when they need to be met to keep a project on track. So that's the benefit of a project manager. Okay, I mentioned that we were going to do two different scenarios today. The first scenario we're going to talk about, we're going to focus on the first part of the methodology, which is figuring out what caused the error to happen. And we're going to use two different methods. One is called a fishbone diagram, and you have that in front of you. And then the other one is a 5Y. And the scenario we're going to use around that is called incidental findings. So both of these scenarios are loosely based on events that have happened here at our hospital. So we're going to talk about the methods you're going to use in the first scenario, then we're going to break into teams, you'll do that scenario, we're going to stop and debrief, and then we'll go to the second scenario. Okay, so the first method is fishbone diagram, and you'll see the fishbone diagram has these components on it. It's a method or tool that forces you to look at a problem from a systems approach. And so you'll take your problem that we have of incidental findings on the X-ray. That's how did we have an incidental finding? You put that in this is the question that you're trying to search for. And it forces you to look at, was there something about the equipment that contributed to the problem that you're trying to solve? Is it something about the process itself? If the process isn't correct, is there a wrong step in there that you can follow the process perfectly but still make a mistake? Was it something about the people? And when we talk about people, remember in human factors we were talking about we've got patients involved, families, many different healthcare workers, providers, nurses, aides, it could be dietary. People can involve a lot of different types of personnel when we're talking about issues in healthcare. So anybody involved with the event is what you would consider on the people side. Then we've got would it be something to do with management? or the environment itself, the layout of the hospital, maybe if pharmacy is too far away, or using the tube system to get labs sent up, whatever might be contributing to the problem, or something about the materials or supplies. Did we not have the right information or the right supplies that we needed that contributed to the error? So this, you're going to think about each bone separately, and sometimes it might, when you start to consider reasons that what might contribute to the problem is maybe it's something that's not even on here, or maybe it is radiology based, and radiology needs a whole bone all to itself. So you can add whatever bones you want. You can change the names, and it doesn't matter a whole lot which one it is. It's just a way to make you think of more than one track of what might be causing the problem. So thinking of other contributing factors. Okay.
All right, I have to be near this microphone, so I'm going to try not to walk away. The next part of this exercise, so first thing you do, you take that fishbone diagram and you're going to figure out your causes. Now, a lot of the times, the first cause that you come up with is kind of the first thing that pops into mind, which means it's really going to be a kind of a surface level cause. So one of the next tools that we use all the time, and I try and use this every day in my work, is a 5 whys. It's exactly as it sounds. You basically go through, and once you find a cause, you're going to ask yourself why 5 different times. It's been shown that basically when you hit that 5 number, you're really getting down to the root of the problem. Because what you may see as the initial cause may not actually be the root of the problem. So that's the whole goal behind this. And really, this actually comes from, the whole concept of this comes from kids. Like, how many of you either have kids, have nieces, nephews under the age of 5 who don't shut up? Yes, we all have those nieces that just want to keep asking, well, why? Well, why? Well, why? They're curious. They're trying to understand the world around them and trying to understand really what is the final issue. So they're really good at doing these 5 why exercises. And it is as simple as it sounds. Now, one thing you'll find when you start doing this is you'll ask why, and it can go in 2 different directions. You may have 2 different answers. So a lot of these 5 whys are not a straight line, like shown here, going towards a target, but really it may branch off into different things. So we're going to apply these 2 techniques as different teams. We have done this already once, and I just want to warn you guys, these are purposefully vague. These are not supposed to be cases. These are not something that, you know all the facts about, you know everything about. So we're not going to have answers. There's going to be more questions than answers in this situation. But that's the whole point. Okay? So in your roles today, I know you guys have been doing this for a while. So the scenario here is you have an incidental findings by radiology of a cancer tumor on an x-ray. So you've gotten the x-ray. It's set it somewhere in there. Put yourself into the shoes. And from us as the system, so think of Curlian Clinic, it was found on the x-ray, and then no action was taken by the provider interpreting the radiology report, for whatever the reason was. The patient arrives a year later and is diagnosed with cancer. This happens a handful of times every year. We see this. This is across the country. This happens all the time. So the question that we're trying to get you guys to solve is, how do we keep this from happening again? All of you, at some point in your practice, will run into this. You'll have an incidental finding on something, and what are you going to do with it? So what we want to do today is take the 2 techniques that we just taught you. So sit down, and in the fishbone diagram in front of you, you should all have, well, every other table has a piece of paper. You're going to try and think through, in a systems perspective, potential causes in each one of those buckets. You can customize some of them as you get down the path, but really try and focus on getting 1 or 2 causes for each one of those buckets. And then if we have time in the 15-minute little exercise, we would like you to pick out 1 and do a 5 whys exercise on it. And you may find that what was your original cause may actually be something totally different. Okay? Lori and I are going to be here wandering around. All of you in the back row, hi guys. Hi in the back row. Hi, hi. Don't forget to sign in. 1. Don't forget to sign in. I don't know where the sign-in sheets are, but sign in. Either in the front. There they are. She's got them back there. So sign in. Everybody needs to be at a table with a piece of paper. It's going to be the first 2 rows are going to partner up, the next 2 rows are going to partner up, and then everybody in the back row there is going to have their own piece of paper. We do not want to have more than 8 people at a table, because once you get outside of 8, then you lose some of the group dynamics in there. Okay, so all of you in the back row, you guys are going to have to come up here in the front, partner with one of these tables in the front. And we're going to break. We're going to take 15 minutes. So at 6 o'clock, we will come back together to debrief this exercise. Hey. Hello. Knock, knock. Can I get everybody's attention back up here? Finish your last couple thoughts on there. All right. So, how many of you struggled on this exercise? Was it kind of making you think outside the box, think differently? Oh, I see a no over there. Uh-oh. Have you done this before? Is that what's going on? Well, that's good. Maybe you should come join us in quality. Come join. Come join. Yes. No. So let me ask my first question. How many of you had people as the largest cause, like had the most causes underneath of it? Anybody? Yeah. But you could have multiple breakpoints involved in the people. That's not too bad, and that's pretty good. So, the one thing that this kind of teaches you to get out of is to say that people are not the only cause that's in there. That's one of the things that we like to hit on in here. Would anybody like to share kind of 1 or 2 causes that they came up with this? Okay, go ahead.
So which area? Equipment, process, people, material, which of them? The people one?
Pick one. Pick 1 or 2 causes that you think are most pertinent.
So we thought people and processes are different, definitely are more prevalent. And then management also goes into kind of process people and management hand in hand. So I just get to a point if you expect just us to come up with more causes related to people. So we thought that the process maybe it's a time sensitive discharge and everyone's still focused on the actual diagnosis and getting it done. And then also based on the TED talk, maybe making a checklist or reporting what are the most important things to get reported, or maybe even a protocol for reporting incidental findings. Also maybe a protocol for a follow-up on incidental findings. That's the process.
So those are great things to think about, and those are very important. The protocols, the checklists. Keep in mind, those are solutions. Those are not causes. So, you actually said it appropriately the first time. It was a rush discharge, and we didn't have a way to communicate, or it was a miscommunication on the discharge orders. That's a really good cause. So your solution after that, which is the next part of the exercise, is build a checklist upon discharge. So that's an absolutely great one. Yes. Anybody else have any other thoughts?
No system in place to get them to follow up. If you're for any issues, they identify you don't have a system that can get this back to the PCP. A lot of times these happen. There's a mass follow up with imaging in 6 months or a year.
Yes.
A system in place to follow that up.
Yep. Did everybody hear that? There's no system in place to follow up with this. That's a very simple process cause. The cause is no process built to follow up on these. There's no verification. There's no checklist that says I must do this. Yeah. Yeah.
Other people process things being who is responsible to do it. So let's just say commission comes in, this patient comes in with,
There you go. Yep.
bacteria or something, right? And then they have a CT scan or something an X-ray and they find this mass or whatever it might be. From a consulting point of view, they ask us to see the patient for stone and we found nothing. So we look at the gallbladder, we look at the bile duct, and that's how it works, right? Everything else outside, it could be a
Mm-hmm. Yep. Yes, I think that's a very good point. It's, she's talking about diffusion of responsibility. So, if everybody's in charge of it, nobody's in charge of it. And that's a big issue with consulting services and these, one-offs that come in. Yes.
But it's a very good point, and actually, I think just based on the why and also based on the processes, like when we try to get the core of the problem is that maybe the lack of the human part of the medicine. That's what's lacking. So I understand that from a consultant point of view, yes, we stick to providing some consult for a current problem, but at the same time, if I, as a psychiatrist, I find some incidental issues, I still have the obligation at least to bring it up to the attention of the primary care team. I don't do that all the time, and no one else is going to do that. So that's the things I think that's missing.
Absolutely. So in that case, it's what is my next step if I find it? Is there a process so we talked about there's no process for follow-up, but is there even a process for escalating these when you find them? So that's kind of the point in there. Does anybody have anything else? Do you have anything to add, Lori?
If this is it true that there is not a escalation process that everybody's aware of? If that, you don't know what it is?
It depends on what it is.
Oh,
We have different ways to escalate.
But there are escalation plans. I was going to say, if there's not, we need to make one.
Right.
If there is one, maybe it's just, there's maybe several of them, and we would make a better way to make them known.
Mm-hmm. Great. All right, so that was our first exercise. So now we're going to move on to the second scenario and the second exercise. As we talked about earlier, now we're going to the back half of our problem-solving framework. So first we've done root causes and brainstorming on the 5 whys, getting down to that true cause. Now we're going to talk about brainstorming. Brainstorming sounds simple. It's actually very hard. There's a lot of studies out there about how to do effective brainstorming. So, we tried to put some tips and hints up here, things that we use in our job to get creative, get new ideas, think outside the box. And among them, think freely. We always love wild ideas. I'm very good at thinking about off-the-wall things. Quantity counts, so more ideas, the better, and most importantly for whoever's going to be our scribe at each table, it's recording every one of those ideas. Making sure they're on paper, making sure everybody sees them, because you don't know which wild and crazy idea is going to lead to the right solution. Try visual brainstorming. Most importantly, that's why you have Post-it notes at your desk. I walk around with Post-it notes and Sharpies on me 24/7, because this is what I do. So it just helps to see all the different ideas that you're coming up with. And stay focused on solutions that align with the causes. So, once you figure out a cause, you want to try and solve that one problem, not something that may be a side effect that you're also trying to solve. We kind of struggle with, I want to solve the entire issue and not just what has been scoped as my problem. So keep that in mind when you're brainstorming. Ideas are great, but if they're not going to fix the thing you're talking about, you can put them down on Post-it note. We'll take them away for later. So that's the first part. We're going to do some brainstorming. And then we're going to do what's called an impact matrix. So the whole point in this is to literally tell you, which solution am I going to do next? Because how many times have you found a problem and now you're like, oh, great, I've got 10 solutions. What do I do next? I mean, we all do it. You kind of get sidelined by, I can fix it 10 different ways. Or I have one process with 10 different breaks, so I'm going to do them all at once. I'm going to fix everything. You got to fix one thing at a time. So very simple. This is not supposed to be a complicated tool. Basically, X, Y axis. You're going to take each one of your solutions that you've put on sticky notes, and you're going to put them on this graphic. So based on the level of impact, so how much is it going to fix your problem? If the impact is very high, that means it's a, very strong solution. It may be an EMR solution or some sort of fix that you can't screw up, versus low impact is kind of like a checklist or, double check on something. Okay. And then you're going to do it on ease of implementation. Something that's really easy, maybe a checklist, going back to the same thing, because it's a piece of paper, you do that, versus something that is very difficult, maybe getting a new piece of equipment, maybe getting the manufacturer to redesign a piece of equipment so it doesn't fail on you. So many different things to do in here, but you're going to take each one of your solutions and you're going to put them on this matrix. This is kind of the fun part. And then what you do is you would look at this and you would say, okay, my quick wins are going to be my easy implementations, high level of impact, and maybe my long-term solution, my 5-year plan is something that's difficult and high impact. And what this does too is, it may help your team focus in on, hey, I thought I had this great solution, but because it's a really low level of impact, we may not want to do it. So it gets your team prioritizing those solutions and saying, okay, that's a really good solution, but maybe it's not the best one for right now. Okay? Yes, it's supposed to be simple. We don't like to overcomplicate things here. Not as an engineer. So, the next scenario. So we're going to use those 2 tools that we just talked about, and we're going to talk about everybody's favorite thing, opioids here. Yes. Remember, we said these scenarios are supposed to apply to you guys. We want something that is something you're going to have to deal with within your practice in the future. This is not in the future. This is current. We all know that this is here. In this scenario, we do want you to step into potentially somebody else's shoes. So, picture yourself as the section chief of general surgery, and you're charged with ensuring appropriate post-op opioid prescribing practices within your section. So, you're in that person's shoes, okay? So, we need you to brainstorm ideas as to how to ensure that you've got prescribing practices appropriate. So we want you to brainstorm ideas, and then everybody has on their desks and tables as well that impact matrix. So we want you to take those sticky notes and put them on your impact matrix. We'd love for you to come up with more than 10. Like we said, quantity is better. So brainstorm ideas, put them on the matrix, and then we'll debrief after the end of it. Let's bring everybody back up here to the front. We're kind of cutting you a little early so we can get out of here quicker. So hopefully that got you guys thinking about what some things maybe that you could start even doing today in your practice. That, thinking maybe outside the box, things that already exist, but, maybe aren't being used as well. So I'm just going to ask for some volunteers because I like volunteering people. Give me one of your solutions.
So we came up with no refills and restriction on the amount and the
Yep.
to have very high impact, and they are relatively easy to be implemented. Also on the very difficult to be implemented and high impact, we have ethics recommendation about how long patients have been on opioids, and trying to hard because we're just making it more restrictive. Checking is hard. Also having the checkpoints in pharmacy, which is already in place, is difficult because we have to choose immunofactor, but it has a very high impact.
Yes, great. So we had the PMP, we had the EHR automatically suggesting prescriptions. Those are some really good ones. Very applicable. What else?
Pre-op counseling.
Pre-op counseling. That's a great one. Yes. Making sure you're having that conversation before you ever even get to that point. That's a great proactive thing. That's very much getting in front of the situations. What else? What else did you guys come up with? Any?
On the role of non-opioid painkillers.
Mm-hmm.
This, it's pretty very high impact, but it's kind of hard. It's kind of not really hard, but just something easy and hard to implement because we turn over a lot. There's no new residents.
So I would rank, usually when we talk about training, Lori will talk about this more, training is a weak solution. It's may have a high level of impact, but it's very hard to sustain. It's really not a good, a strong solution. So training is kind of one of many when you start talking about solutions. So keep that in mind.
Changing nursing culture for new nurses in the hospital.
Yep.
The number of phone calls we receive that someone has 10 out of 10 pain.
Yes.
That they're sleeping.
Uh-huh. Yep. So if we look at the root cause of that, of pain being a 10 out of 10, I know I coached a table over here. Yes. What's a very hard implementation that you could do in kind of response to that?
Yeah, we were talking about maybe getting the government to choose back on setting pain as a vital time. That's a unrealistic bar for us.
Mm-hmm.
Patient satisfaction.
Yep, so there's patient experience, there's removing pain as the fifth vital sign. That's one of those that's really an out-of-box solution, but when you start looking at truly what the root cause of opioids was, it really kind of started there. It was, way back in medicine, it was you must be at a pain level of 0. If you're not, then I'm doing something wrong. So now we're realizing maybe that's not the best answer. So practice is changing, and the government is very slow to change. So any other out-of-the-box solutions, maybe with pharmacy, with drug companies? Any?
Creating something in Epic that would generate for you a average morphine milligram equivalent dose that your patient got over their hospitalization, so you could use that when determining how much to prescribe them for when they're in the hospital.
Yeah.
That would be generated like during discharge for reconciliation and pop up.
That's a fantastic idea. So you're using it to understand basically what their current prescription is so you don't overprescribe them. That's a great solution. How many of you said use the PMP? More, better. Yes. So one thing that, we always want to talk about that because that's been in place for about a month now. So that has been a new add to Epic. So we definitely want you guys to be using that and you have to be documenting in there. Otherwise, somebody was saying you might get a nastygram. Not totally sure about that, but make sure you are using the PMP. That's why it's there. It's a state regulation. It's coming down. One of the things, just to kind of encourage you guys that the whole point of this was to think outside of the box. One of the solutions that the last group had come up with was saying, why don't we have dissolvable pills? After 20 days, the opioid dissolves. But, why not? Why not? But you can make things, yeah, water technically evaporates.
Starlight evaporates at a very, very slow rate. Water evaporates at a high rate.
But so, yes. So, but keep in mind, but the whole point of this is to think outside the box. You're supposed to come up with wild and crazy ideas because you can never become better if you don't think outside the box. The definition of insanity is doing the same thing over and over and over again. So, these are just kind of things that we want you to think about. Maybe that's not the perfect solution, but maybe it is something about a dissolvable pill. So, we appreciate your having fun in these exercises. Hopefully this is something that you will apply. But real quick before we kind of get into our closing, I'm going to flip it over to Lori. She's got 2 more things to talk about, and then we're going to get you guys out of here in 10 more minutes, okay? Promise.
Okay, I'll take that challenge and make it even a little more quick. We had talked about different kinds of interventions, and we just wanted to highlight this, that Kristen was mentioning that there are different strengths of interventions. And so along this continuum, some of our interventions are relying on humans or one individual, like the training or double checks, even policies and procedures. Oftentimes our healthcare interventions are based on one individual or training individuals. That's always going to be a weak because it relies on humans, and we know humans make mistakes, and we have turnover and all the things we talked about. We prefer, if possible, to try to get stronger interventions that rely on the system or eliminate the possibility of even having the error. So engineering out the problem or force functions where it's impossible to do it wrong. That's what we'd like to do if possible. Like the dissolving pills. If they don't even exist, you can't take them. So something like that. So anyway, just be thinking along that continuum. Oftentimes, these engineering fixes take a long time. If we need to have a solution within 45 days for CMS, sometimes we tend to jump at these quicker solutions of education. But the longer term, and we've heard several great examples tonight of changing EMR, the group back here of calculating based on what the opioid prescription is as an inpatient. That's a great idea, as opposed to just a standard protocol of 20 pills or 30 pills. So putting a little thought behind it. But there are many different ways of doing this. Even checklists, the timeouts in surgery, even that is not a foolproof intervention because it relies on humans to do it correctly. So just keep that in mind as you are brainstorming these different solutions. Where's the clicker? Been a long day. All right, so the last one is let's just take a couple minutes to debrief what we learned. We know that you're going to be doing different, you're going to have many different capacities of problem solving throughout your whole career. So just remember there are many different kinds of tools, and use the tools you need at the time you need them. You will almost always have some PI support, some performance improvement support, or human factors people in your healthcare system. Reach out to us. It's what we do all the time, all day, and we love to solve problems. So reach out and get the help you need when you need someone to give you a program manager or to help you through some of these different methodologies. And basically remember these principles. If it's a human mistake, look a little farther. There's some reason why the human is making a mistake. Something about the system is responsible for that, almost always. Look beyond just your area of your department. So that's the systems approach. Just beyond your sphere or your influence, go outside of the box, outside of just your area of focus. And know that these engineering fixes are hard and it takes a long time, but it's worth fighting for the resources to make it change, because that's what our ultimate fix will prevent us from making mistakes in the future. Okay, do you have anything else to add to that?
Make sure you guys signed in.
Everybody sign in.
Please.
Okay, thank you so much for your time.
Thank you. Appreciate it.
Thank you.